Welcome, everyone. This is being hosted by Washtenaw County League of Women Voters, and my name is Sarah Fink. I'm head of the healthcare reform group here. We are an advocacy group, but this is an educational event to inform other league members around the state about public health in our state. And I'm sure as league members, you have heard this all before, but you are all aware that the league is a nonpartisan grassroots organization whose mission is empowering voters and defending democracy, and that we do not support candidates or parties. But as part of our empowering voters mission, we provide education on issues of public concern, among which is, of course, healthcare. And this talk by league member Janet Olszewski, who has an MSW and has had an extensive career in health policy, health management, public health programs, much of it working for the state of Michigan, including, I believe, in the Granholm administration. And she comes to us today to inform league members about the history and the future of public health in our state. So welcome, Janet.
Thank you. All right, let me get the share screen going here. There you are. Okay, here we are. Can you see my screen? All right,
Yes.
good. Well, thank you. Good afternoon, everyone. Thanks for taking time out of your Sunday afternoon to talk a little bit about this subject. As Sarah indicated, I do have an extensive career in state government all around health and public health. But I come to you today as a member of the Michigan Public Health Advisory Council. And I want to talk about a call to action that we issued late in the fall of 2023. And what we feel needs to happen in the state to assure that we can keep Michigan as healthy as possible going forward. So let me start with the Public Health Advisory Council, who has sounded this alarm and called for this action. It's a group that was established by executive order in 2017. So when Governor Snyder was in office, and it historically, there has been a state level public health advisory council in the past, but when government reorganizes and departments merge, things fall off to the wayside. So it was reestablished in 2017. It has 26 members representing a variety of disciplines and includes 5 state agencies because public health responsibilities are handled at the state level by several different agencies. So those 5 state agencies that have public health responsibilities sit as non-voting members of the group. And all the members are appointed by the governor. So this is the group that in its deliberations, certainly I was not a member of the group during COVID, but most of the members have been there throughout the COVID pandemic, and post-pandemic really decided that we needed to take a look at public health today, where what has happened to it, and make some clear recommendations for the state going forward to strengthen it, because it became clear that there were some holes in the system as we went through the pandemic. So why the call to action? Why is public health important? And it really is critical to the health, well-being, and economic prosperity of Michigan. And when I use the term public health, I use it broadly, but organizationally, I talk largely about state and local health departments and their partnerships with healthcare providers. Often, public health is overlooked because if you're preventing something from happening, what's there to see? So if your water is clean when it comes out of the tap, if your food is safe that you eat in the restaurants, what's there to see? So it's often overlooked. It's often misunderstood. It's often confused with medical care and health insurance coverage. Certainly it looks at those things, but it is much broader than that. We know that in COVID-19, the pandemic overwhelmed the system. It overwhelmed the governmental public health system. It overwhelmed our healthcare delivery system. And we need to deal with that. And also social media misinformation, and in some cases deliberate disinformation, has complicated the picture for us in the last 5 to 10 years. Back when I served in state government, we didn't have X and Facebook and all of the other social Instagrams and Snapchats and the instant communication that exists today. So when we look at public health, I just want to spend a few minutes kind of talking about a history and sort of where we are. In Michigan, public health, governmental public health is 150 years old as of 2023. We established our state and local public health system in 1873. And at that point, just to think back, typhoid fever, diphtheria, tuberculosis, polio, waterborne illnesses were killing Michiganians. Now we see it's much more chronic disease, but back then it was infectious disease. In 1921, our state had the highest death rate from diphtheria in the world, not just in the country, but in the world. And we were able to cut that death rate from 1,200 per year to less than 40 in just 2 decades. And that was largely through community level public health interventions and the creation of a state lab for testing and coordination of laboratory activities throughout the state. And today, our state laboratory remains one of the premier laboratories in the country and is considered a level 3 testing lab for the Centers for Disease Control. And we routinely, it certainly coordinated the entire testing laboratory response throughout the state during COVID. And it's regularly used to test samples of pathogens and chemical agents throughout the country. Also, just a couple of things, you know, we were the first state to put fluoride in the water in 1954. And in Michigan, public health experts were the ones to identify a positive link between using iodine as a preventive measure for goiter, and iodine was put in table salt and is still in table salt till this day. So in our public health efforts, we've actually increased life expectancy in this state by about 30 years. Those community level efforts, as opposed to individual medical care, have increased life expectancy by about 30 years. So when we think about public health, this is just, you know, these are some of the things that we don't think about on a daily basis. I mentioned a couple already. Septic systems clearly are an important, and sewage systems, and that's one of the purviews of public health. I mentioned food, not only restaurants, but packaged food, and of course, recalls of food in your grocery stores, etc. We also do we observe and participate in individual care. You know, we make sure children and adults are vaccinated. We have emergency response plans in place, family planning services. Reproductive health has been the purview of public health for a long time. Over the course of the several decades I worked in government, we saw family planning go from being delivered through local health departments to being delivered through, and Planned Parenthood, to being mostly delivered through Planned Parenthood and healthcare systems, less on the public side. But there are partnerships with the healthcare system. We do community-based screening programs. The surveillance of communicable disease is the purview of public health. And of course, monitoring access to care and assuring that everyone can get healthcare regardless of their health insurance status is one of the key activities of our public health system. And often we forget that there's a veterinary component in public health as well. So pet food is an important piece, and veterinary care is an important piece of public health. We do know that infectious disease is often transmitted from animals to humans and back again in some cases. So veterinary health is an important piece. So in public health, how does public health work? Essentially, there are 3 core functions for every public health department, and that's taking a look at what's going on in their community, assessment. So what are the needs of that community? What are the needs of certain populations within the community? Developing policies and programs to address those needs, and then assurance, making sure that people get what they need, that problems are being addressed. So if you, this diagram here, the assessment, policy development, and insurance are on the outside of the circle. And then within public health circles, what's known as the 10 essential services form the body of the circle. So, you know, the health departments, the way they do assessment is through surveillance. They do surveys of population health. They do investigations of outbreaks of disease, et cetera. They do a lot of communication and policy development. They communicate a lot through public forums, through advocacy, et cetera, with elected officials on what are the problems in the community, what could address those problems, and how to address them. They work with communities to amplify the community voice in solving their own problems. They have state and local health departments have regulatory authority to take action, and they will create policies that promote health. They often advise other agencies in terms of their own policies. For example, in a local community, if you build sidewalks and parks, a community can be healthier because people can walk and be outside and participate in physical activity. So there's often synergy between a health department and other departments in local government. And then in assurance, there sometimes health departments will provide services. For example, I live in Ingham County, and our local health department provides several community clinics that provide primary care for folks who are uninsured, but it also provides care for people who have Medicaid and even who have private insurance. They put clinics in communities where there's less access to physician services, less access to screening services. And several other counties do the same, or the community health centers, the federally qualified health centers throughout the state do that, and health departments work with them. So there's a variety of activities that the health departments use to accomplish their work. In Michigan, we have 45 local health departments. The white counties are individual county departments. The one exception to that is in Detroit. We have a city health department and then a Wayne County Health Department. There's also a City of Dearborn Health Department, but that is not part of the, I would say, official state-local network. Certainly the state works with them, but from a regulatory and a public health code standpoint, Wayne County Health Department embodies Dearborn within its sphere, and it works with the City of Dearborn Health Department. City of Detroit Health Department is autonomous in its responsibilities. So this public health call to action, the Advisory Council, as I said, has put out this report after doing a series of structured interviews with stakeholders. And we interviewed healthcare professionals, hospitals, physicians, clinics, public health departments, state agency staff, the general public, the nonprofit sector, the community services sectors. There were a variety of people who we talked to in emergency services in structured interviews, and asked them about their experiences and collated their responses and their recommendations. And then the Advisory Council spent several months deliberating on how we could improve what was going on in Michigan. And overall, the report suggests two major themes, which is equity. We have to prioritize equity because the pandemic laid bare what many of us already knew, which is there are very disparate experiences and healthcare outcomes for different populations in this state. For example, when the pandemic started, African Americans in Michigan died at rates that were twice as high as those for whites. By 2022, we had totally eliminated that gap in COVID-19 deaths, but it took a lot of work to do that. And that is just one example of the lack of equity that we see in the state. So equity has to be front and center on everything we do in public health. And then the other thing that's really important is we need to understand what success looks like, and we need to measure for it appropriate. The data systems we have had in the public health sphere have been seriously lacking, and we often can't figure out the results of the actions that have been taken. So within that, there were recommendations around strengthening the public health infrastructure in Michigan, which means making sure we have adequate financial support, that we have strong communication amongst all the state agencies that have public health responsibilities, as well as state and local within their communities with the healthcare delivery system, that we develop better data management systems, and that we strengthen the legal foundation. We certainly, while we have a really model public health code in the state, there certainly were legal issues that we found in the pandemic. And then, of course, the trust issue, which is paramount. And we really need to strengthen the relationship with communities on a day-to-day basis so they know who public health is, and that we listen to them, and that we have better long-term relationships with them so that in an emergency, in an urgent situation, there's already trust that's built. You're not trying to build trust while you're putting out the fires. Moving on, so what specifically did we recommend? And I'm just going to focus on the left-hand side here. You have a link to the report in your in the last slide, and also in the invitation to attend this meeting. So if you'd like to look at the whole report, it's the link is available to you. One of the first things is improving the connection of public health to the healthcare system. I mentioned earlier that much of what we see now is chronic disease, and that's what affects health outcomes for people. And chronic disease is diabetes, it's heart disease, it's stroke, it's high blood pressure, it's all of those things. And that often is addressed through the medical care delivery system. But there are also community-based initiatives that are needed. We, one, need to make sure people have access to the medical care system. In addition, we need to make sure that outside of that doctor's office, they can get the foods they need to eat a healthy diet. They need to be able to get the exercise to have a healthy lifestyle, an active lifestyle. They need to be able to get their medications. They need to be able to store their medications properly. They need to be able to get rides to the doctor. If they don't have a car, they need to be able to take the bus. They need to have money to take the bus to a clinic. So there's all sorts of social needs and non-medical needs. And so we really need to strengthen the connections. Also, when we're dealing with infectious disease, it's bigger than any one medical care delivery system in our communities. And we need that broad communication and response from all healthcare sectors. So we need to, again, improve those connections on a daily basis so that when we need them for emergencies, they're there. The other thing we discovered during the pandemic is that it may be a function of term limits. Many things about knowledge are, but with legislators turning over on a regular basis, they didn't have a good understanding of public health and what it did and what it meant. So we feel as an advisory council that we all need to take responsibility for making sure that legislators understand what public health means in Michigan, what the governmental responsibilities are, and do that through education and really district level profiles of community health in their community, so we can make it real for them on a community level, the people they represent. And then third, we also discovered that for the most part, public health, the public did not know what public health did. They had no idea that, you know, health departments are involved in the kinds of things they are on a daily basis. And it was sort of a shame on us moment, because, you know, certainly public, you know, the local agencies and state agency can be much better engaged in helping people understand what public health does. And, you know, just it's not always good enough to just prevent something from happening if people don't even know you're the one preventing it from happening. And then data systems were critical. And this is a multifaceted issue, but it was very clear, especially as COVID started. I can't tell you how horrifying it was to find that, you know, 10 years after I left state government, we were still hand tabulating things that came in from local health departments because we didn't have the data feeds that would work quickly enough. And you had separate kinds of data feeds coming from hospitals, from health departments, from federally qualified health centers, and trying to, uniformly figure out what was going on the ground became very difficult. And over time, the systems got better. But one of the challenges has been that we have unique data systems for different functions in healthcare. And that's a real problem, because if the funding was, let's say, for heart disease, they collect a certain type of surveillance. And if emergency preparedness funding dried up in the last decade. And so some of our broad data infrastructure needs were left unmet. The other thing is that being a public health leader in 2024 requires a different skill set than it did in 2014 or 2004 or 1994. Again, some of it has to do with the internet, the instant communication age, the pervasive amount of information as well as misinformation that comes out, and the ability to be constantly interacting with folks and developing great communication skills so that you can be heard amongst all the different voices out there. And coalition building becomes really important, and leadership, being a servant leader, becomes important, helping others deliver the message. And we haven't done a lot of leadership development, especially within the state, for local leaders. And so there's a recommendation to really enhance the leadership training in public health. And then communication can always be improved. There's no lack of the need for communication. We tend to communicate about what's going on that day, but we often don't establish regular channels, and there has to be consistency in messaging. When we certainly learned during the pandemic that when multiple agencies were involved, state agencies involved, they didn't always coordinate their messages, especially at the outset. And so that's really critical, and really getting communication straight at the federal and the state level so that the locals get consistent messages is really very critical as we move forward. And then we don't need just funding, but we need flexible funding. Because what you find in public health is you may have hundreds of millions of dollars in the state public health administration, but it's earmarked for programs. So it may be specifically earmarked for blood pressure control or diabetes control or children's lead prevention programs, or this program or that program. And of course, they all come with their own data sets. And what we need is to have some flexible funding, because what happened in the pandemic is there was funding, but until the COVID funding was passed by Congress, you couldn't move money around. It wasn't fungible. And so the idea that locals and the state, to a certain extent, need more flexibility in the types of funding they get so that they can respond to their community needs, so that they can, in Traverse City, what one needs is going to be different than what one needs in Ann Arbor or Lansing, so that they have more flexibility to respond is key as we move forward. So that's what the general gist of what the recommendations are. And I'm looking forward to our conversation, but before I end, I kind of want to talk about, well, what can you do as league members? If you already, know a lot about your health department, great. If not, you can certainly follow your health department on Facebook and other social media. They are on, each one of them is on social media, and you can learn about what they're doing. You can learn about where they are, any public forums they're holding through their social media outlets, and visiting their websites. You can share information to your own social media that they are producing. They produce public health messages all the time. You can share that information on your media. You can attend their Board of Health meetings. They all have boards of health in some capacity. well, I shouldn't say they all, most of them have boards of health that are advisory if they are single county entities because they are part of county government. So they have their own local public health advisory councils. There are a few exceptions to that. If they're a multi-county jurisdiction, then they often have a board that governs it, and you can attend those board meetings, but their meetings are public meetings. And then also a Board of Commissioners meeting at the county level often has a health agenda, and you can attend those. And you can engage with staff of the local health department on issues that matter to you. So I know this is a healthcare reform advocacy group. You can engage with your health departments on the issues that you see around healthcare reform that are important. And the other thing you can do is certainly support local financial support for health departments. We have revenue sharing in the state of Michigan that has never kept up in many decades. It hasn't kept up with the promise that it made. We've been doing better since COVID. And since the state's budget coffers have been in better shape. When I was director of the department from 2003 to 2010, we were in budget crises all the time, and we didn't do very well at funding locals. But there should be local tax support for these kinds of functions. It's an important community function. And you can also communicate with state legislators on the need for ongoing support for a strong local and state public health infrastructure, along with the delivery system that's so important. And then I've just provided you a few resources. The first resource listed here is the council's recommendations, so you can read the full report there. The second is just kind of an interesting graphic that the Michigan Department of Health and Human Services published last year that talks about public health and its accomplishments as well as its challenges in the last 50 years. For example, the PBB crisis that we experienced in Michigan in the 1970s is there as one of the challenges. The Michigan Association for Local Public Health, which is the third piece there, is the organization of local health departments in the state, and they have a number of resources on their website. And then finally, there is a Michigan Public Health Association, which is an association of public health professionals and general public interested in the issues of public health. And I've given you their website. They're an affiliate of the American Public Health Association. And so in case you're interested in seeing what they are about or becoming part of that organization, it's there for you. And so I think with that, I'll end my screen share. New share, how do I end my screen?
Hit your escape.
Oh, hit my escape button. There we go. Got it. Stop share. Thank you. All right. So now we're back to the screen. So thank you very much.
Are there any questions in the chat? Yeah, that was a wonderful, thank you so much, Janet, for providing that historical and very complete. Touched on so many facets of public health and its intersections with other areas of health. So I guess the first thing is, do we have any questions in the chat?
The one question in the chat is, after the experience with COVID for infectious disease and the Flint water crisis as an example of environmental health disasters, what will it take to bring more attention to our public health system? You've talked about increasing communication, but more specifically, how can that happen?
Well, I have to say that funding's an issue. It's always sexier, to be honest, to provide funding for healthcare coverage. So for example, when I was director of the state health department, I never had any trouble convincing people to fund the Medicaid program. I had a lot of trouble convincing people to fund, preventive care at the community level through local public health, because again, when you're preventing something from happening, it's harder. It's just a harder sell. So I think that helping people understand what it means. I think the good thing about COVID is that it reminded us infectious disease is alive and well and we need to be prepared. And I don't think anybody who's interested in health disputes that. How we respond to it then becomes an open question. And on the Flint water, I think that's the same thing. There, unfortunately, I think we developed a huge chasm of trust because it was viewed as government causing the problem, as opposed to even in anything else where it was perhaps not responding as well. But in this sense, it was government causing the problem. So I think trust becomes a big issue, and that's hard work. That's at the community level, day to day, talking with people, listening to people, hearing what they need, and responding to that. And I think that that's just really hard work that we have to do in this state. And we've been in the process of it. I think things are a little bit better than they were, but it's a challenge. And in a term limited legislative arena, I think it's a consistent challenge because you're educating all the time. So I think education, information, and making sure the public's aware of what we do and that it's valuable is important.
Very good. The next question is, what can be done to avoid politicization? I'm not saying that too well. Politicization of public health organizations, such as happened in Ottawa County.
If I could answer that question, I'd be a wealthy woman, because it's not happening just in Ottawa County. It's the most extreme example in the state of Michigan, but it's also happening in other states. And I'm not sure, you know, in Ottawa County, the health department is a department of county government. So it's the county commissioners who are creating the politicalization. And so in that sense, you know, the voters have to vote in different county commissioners if they want that changed. I don't know how you avoid that. There was a time in Michigan where the governor did not appoint the public health director. There was a separate board of health, but the governor appoints the board of health. So whether it's at the federal level, the state level, or the local level, to a certain extent, government gets involved in who it appoints to then govern public health. But some people believe that at least if you create an arm's length relationship where there's a separate board of health that actually has a governance authority, it can help. I've seen it go bad in both directions, so I'm not convinced that's true. But I think people, the public, have to decide that this is not a partisan issue, that you know, we care about our communities and our own health, and that the way to do that is to allow it to operate in a scientific manner. I think we are seeing a period of time too where, unfortunately, public health may be viewed as telling people what to do as opposed to giving people information to help them make their own decisions. And public health experts are changing in that regard and giving people more information, make their own decisions. I think we've evolved as a society. We don't want our doctors telling us what to do. We don't want public health telling us what to do. We want information to make our own decisions. And I think that's going to be really important as we go forward, figuring out how to do that well. I see somebody in the chat whose father was a sanitarian. Yay for your dad. That's thankless work.
Sue, I see another question, and actually I have a couple of questions too. One is the health department involved in recommending availability of women's procreative needs, you know, healthcare around reproduction? I don't know if local health departments do that.
Some do. You know, Ingham County, for example, is quite active in that, but that's because they they are a department of a county where the county commissioners support that activity. So the elected officials of the county support that activity, so they get to do it. Ottawa County, as we all well know, it cannot do it. Now, the way we're structured in Michigan, the state can if a local health department fails to carry out its responsibilities, the state can ask another local to do it instead, or can do it themselves. So they can find other actors in a community to take responsibilities that a local health department doesn't. But in many counties, family planning became, and procreative choice became the first hot button issue. And local health departments divested themselves of that responsibility years ago. Moved, and Planned Parenthood and other nonprofit organizations took it over. So it really varies by county as to whether they get, how involved they get, and how public they get about their involvement. Judy Jeff mentioned that the community health centers do a lot of work. The federally qualified health centers do a lot of that work in counties, and the county health departments often work closely with them.
And their funding is always unreliable, isn't it?
Well,
federally
they get federal
qualified?
grants. The federally qualified health centers get federal grants to operate, but then they also get Medicaid funding and Medicare funding and private insurance. They get health insurance payments. So they bill health insurance for anyone who has that coverage. And in Washtenaw County, Ingham County, and Genesee County, we also have county health plans that provide coverage for people who are uninsured. So in those counties, the federally qualified health centers get money from those health plans as well.
Good. Sarah?
Yeah, I have a friend who's very involved, has been very involved in her career in federally qualified health centers here in Washtenaw, and I think in Wayne County. And she has told me that the funding fluctuates, and they're
It
always
does.
looking for funding and grants, and yeah, despite all those potential sources of
Correct,
income.
because nobody ever pays you what it really costs.
Yes.
And we could have a whole nother session on health insurance, but you get a certain rate, the Medicaid rate, the Medicare rate. Those do not necessarily reflect 100% of your cost in providing that doctor's visit, that dental visit.
So I have one more question about your the recommendations. So you didn't mention there are a number in under each of those 7 recommendations. There were some timelines and some deadlines, and I wonder if those have been, if you all have managed to implement any of those. I think there was one due for the 3rd quarter of 2023 and one for the 4th quarter.
Right. And we rely on the state health department staff to do implementation. And our meeting is coming up this Thursday. So in some ways, this meeting's a little premature in that there hasn't been a report posted, and our December meeting was canceled, so we didn't get the report. So I believe there have been discussions underway, and I know the state is working on some things, but part of it for them too is funding and prioritization. So, and once again, they have the same struggle I had when I was there, which is getting people to pay attention to what's needed.
Yeah, for the preventive.
Right, for the preventive aspects. It's like, otherwise, we're back at it again when a problem arises.
One of the, and another related question is one of the actions was having a dashboard, I think, or some better connection to state legislators. And I wondered if there is our local rep here, Carrie Reingans, is a public health, just a health advocate, and she has put forward the single payer plan. Do you know her, and have you identified her or any other representatives who can assist you and be part of integrating better?
I don't happen to know that representative, but I do know ones from as a league member, I know my representatives more than I know the others. And because I don't work in state government anymore, I'm not meeting with the others on a daily basis, but certainly the department staff and all of, those of us on the council come from different geographic areas. So we're all working through our respective representatives. And then the department is working with the committee members, both appropriations subcommittees, as well as the policy committees in both the House and the Senate.
Good.
committee.
A couple more questions have popped up. Please repeat the 3 counties with county health plan.
Ingham, Washtenaw, and Genesee.
Okay. Then the
And those
next,
are supported by local millage funds. So there are property taxes that the voters have voted in those 3 counties that support providing coverage to the uninsured, who in this day and age are often undocumented immigrants.
another question, I'm especially interested and concerned about the unhoused in Michigan. Is this an area of public health focus as well?
You know, that's a great question. And when I began my career, we used to think about public health and social services very separately. We no longer do that. And for example, in Michigan, you have the Department of Health and Human Services, because if somebody doesn't have a house, how can they possibly live a healthy life? And so you see all sorts of interest in documenting homelessness and figuring out how to deal with homelessness from public health. It's certainly a priority within the American Public Health Association. Within health departments, it varies by jurisdiction, how active they are versus how much they're part of a larger coalition. But I will say another piece is it's becoming critical within Medicaid programs. So within Medicaid programs now, the federal government has allowed states to start letting health plans work with community-based agencies and public health departments to try and get people into stable housing, and use Medicaid funds to assist in that. And the whole effort at using community health workers is supportive of that, where you're trying to help people stabilize their social support system so that then they can be healthy. And yes, it is a priority of public health. And that's what you need to achieve equity, truly, is more focus on the social needs.
Another question has popped up. Can you please comment on the new law to test all Michigan's children for lead poisoning?
It's a really important law. Our knowledge of lead and lead poisoning has grown tremendously over the course of my career. I think back to when I was a child, and at that point, I think the CDC levels for lead poisoning were up around 50. Now we're at less, essentially at 5 and less. So we've taken, over the course of the last 5 decades, we've learned to take lead and lead poisoning much more seriously in this country, with good reason, because it affects children for life. And it's so I think it's very important. And we've tended in the past to focus on low-income children because they were often in substandard housing, and lead paint was a source. Flint taught us that water can still be a tremendous source, and we are now finding that as you test water for lead in schools, in elementary schools, there's lead in water supplies in a lot of older schools that are in different communities. And pediatricians in particular were kind of not looking at lead poisoning for whole groups of children. And the law is a way to get people to pay attention. It's one of those things. It's less about punishing people for not doing it. It's more about trying to bring attention to the fact that every child really should be screened for lead. And if there is an elevated lead, we need to figure out the source and get rid of it, because it will affect them permanently if we don't.
That was one of the benefits of Head Start.
Yes,
when
absolutely.
I had students in Head Start, that was a requirement. And yes, those children were lower income students, yet they had the benefit of
Right.
that attention.
Right. Yeah, I mean, just lead paint, for example, if you're in a house that was built before 1974, there's layers of lead paint underneath. And, you know, that could be in any, that started becoming a problem for middle-class families when there was gentrification of certain neighborhoods in cities. So, you know, it can be all over. I was surprised, to read that if your house was built before 2004, you should consider getting a water filter for your faucet, because still could be some lead in your pipes. Now, in Lansing, we live with a very good public utility company, the Board of Water and Light, who's replaced all the water service lines in their service area. So we have no more lead pipes in Lansing, but that's not true of many communities.
Not true of Ann Arbor. I'm pretty
Yeah.
sure there's still lots of lead leads.
Right. So that's why we need to test.
There's another comment or question. I haven't got to the end. Thank you for your response to my lead poisoning question. I worked in a local New Hampshire public health department in the early 2000s when a child died from lead poisoning for the first time in decades in the United States. She was recently arrived African refugee living in substandard housing. Such an important issue to protect Michigan's children.
It is. You know, and it's something there are many things in life we can't do anything about. This is something we can solve. So we need to.
That was our last question or comment.
What a great
Okay,
discussion.
I would actually like to add one more question and then close with a couple of general issues that I think are important for healthcare. So my question is, so some of us in the healthcare advocacy field have been working to promote in the advocacy part of the system to working on single payer. And I wondered, just would the interconnections among all these moving parts in state and local health and health providers, would that be simpler and more effective if there were a single payer system? Or,
Maybe, but not necessarily. I have found in my time that, you know, putting things under one organizational structure to get better coordination sometimes works, sometimes doesn't. It's all about leadership, and it's all about people wanting the connections to be made that makes something work. And you can do that with health insurance exactly the way it is today, and public health exactly the way it is today, if you have the right people at the table. And it's very challenging to get single payer. So, and single payer, I mean, let's take a look at the Medicare program, for example, great example, and Medicaid for that. You know, we have almost half of the country is covered by governmental insurance already in Medicare and Medicaid. Some of the worst coordination in the world takes place between public health and those two programs at the federal level. So, and they all work under the same, you know, administration. So maybe, but it doesn't have to be true.
Yeah, my understanding is that the Medicare, Medicaid section and the public health section under HHS are quite distinct. And
they're very distinct, separate deputies, separate everything.
Hardly talk to each other.
Right. And won't share data. Public health often can't get Medicare, at least in the past. I think COVID has changed a lot of that. But in the past, it was very difficult to exchange data.
And I think that will do it for us. Anyone have any final comments or questions?
Just a thank you to Janet for coming and being with us.
So I guess we can now say this meeting is at an end. Thank you very much, Janet.
All right. You're welcome. Enjoy the rest of your afternoon.
Yeah.